Hello, dear colleagues. I hope you all hear me and can see me well. If something is wrong, please write down in the chat and I will help you to set up everything. So today we are having the question answer webinar to the course Composite Restorations in Primary Anterior Teeth. And I would like to thank all of you for joining this course, and I hope that you got the useful and interesting information during the course and you will use it during your everyday clinical practice. And today I'm here for you to answer some questions that maybe you have got during the course, during watching the videos. And before we started this webinar, each of you got the Google form where you could write down the questions so that if you cannot be present live today, I could answer those questions and then you will get the recording of the webinar. So I would like to say some organizational questions first. And first, I will start answering those questions which were sent to me before in those Google forms. And then at the end, when I answer all those questions, you can write down your own questions in the chat and we will proceed discussion. And of course, I will answer all your questions as well. So I think we will start. Now let me switch to the screen demonstration so that I will go to a small presentation. Okay, so let's go with the first question. And first question was from one of the doctors, and she asked, what are my remineralization protocols before doing composites for patients with poor oral hygiene? So I would like to show you this clinical case. And let's discuss some remineralization protocols according to the age of the child and to the clinical situation. Of course, they will be different for each patient, for each clinical case. But usually when I'm dealing with such small patients, as you see in this slide, so this is something like 1 and maybe 2 months year old patient or 1 and a 3 months year old patient. And you see that there is some early childhood caries. And in such situations, it's important to understand that these patients do not brush their teeth quite well because they have sensitivity. And honestly, my main goal is to use some remineralization substances which will help to reduce this sensitivity. So in my practice, I choose this product. It's called Tifenfluoride, and it has 43.5 thousand ppm of fluoride. Also, it contains copper, which has some antimicrobial activity, and it has some calcium hydroxide ions. This product is mainly made for desensitization, and if you go to the evidence and you search for some evidence, there is not too much articles published about the remineralization properties of this product, but there are some which say that this product has very good desensitizing ability. And honestly, I see it on my patients as well, even in some molar incisor hypermineralization cases. When you, for example, blow with the air on a sensitive tooth and the patient says, ow, and then you just apply this substance, and after 1 or 2 minutes of this substance being on the surface of the tooth, there is no more sensitivity. And what I like a lot about this product is that it doesn't stain the teeth. So if you, for example, compare it, let's say, to silver diamine fluoride, which also has a good desensitizing potential, if you compare those both products, this product, the Tifenfluoride, it doesn't stain, which is very good, especially for the anterior segment. So if you would like to try to use this product, what I would suggest you to do is first to clean the surface of the tooth, just with using a toothbrush, a circular toothbrush. And then I take the enhanced polishers. I also show these polishing cups to you in the scheme for polishing composite restoration. So I really like this ones, and I use them a lot in my practice. And I take this enhanced polishing cup and I polish the surface of the tooth to remove the softest enamel layer, which cannot be regenerated. Okay, after that, when I get a smoother surface, by this I create actually a better surface for cleaning. And if the surface is more smooth, the plaque is not accumulating too much on it. And this is one of the reasons why I use enhanced polisher. And the other one is that the deeper layers of enamel are easier to be renovated, let's say regenerated with the material which I'm using. And after that, I apply Tiffin fluoride, and it contains two liquids. So I follow the instructions of the manufacturer, and it takes around 2 minutes for it to dry on the tooth. Sometimes it's even faster. And as you will, if you try to use it, actually, you will see that the sensitivity is relieved immediately, because after polishing caries surface, sometimes we have a little bit of sensitivity, right? And our goal is to reduce it so that the patient will go home and parents will be able to brush the child's teeth quite well. So after this application, what I do next is I prescribe the prevention program according to CAMBRA. I think you should be familiar with this system. It's Caries Management by Risk Assessment, which was developed by Yasmin Crystal and John Featherstone. And you can go online and search for some questionnaires from this CAMBRA system and maybe put it into your own practice as well. So it includes diet modification. Of course, it includes prescribing some fluoride toothpastes, some mouth rinses depending on the age of the child. Sometimes it includes even baking soda, rinsing, mouth rinsing, or some wiping the teeth. So if you go online and search for these CAMBRA protocols, they have different caries risks, and they have schemes for each caries risk group. So I use them in my everyday practice, and this is what I prescribe for the home care. Of course, we pay a lot of attention to the diet of the patient. It should be first balanced. Second, we should try to reduce simple carbohydrates as much as possible. And I care a lot about the nutritional support as well. And we take some blood tests to see if there are some nutritional deficiencies. And if there are some, I also try to correct them. So this is basically what I do with the small children. And if, for example, I have a patient like this, who, as you can see, is a teenager. And of course, the teenager can do some more stuff and can sit in the chair for a longer time. So we can choose some maybe more difficult schemes. And in such cases, I either use the biomimetic remineralization, which actually implies using hydroxyapatite products. And these are some products which are available on the market in Ukraine. And I think you all should have something like this, because BioRepair is an Italian brand, and they have the remineralizing gel also with some trays. They are actually standard trays, but it's very useful because the patient can use this tray and apply the remineralizing gel easily. We don't need to make them some individual trays. And this gel is concentrated. So for example, first I apply it in the clinic, then I prescribe this gel for 2 weeks to apply it during home care. And during that period, they do not use any fluoride toothpaste. They use the hydroxyapatite toothpaste. Why? Because if you use fluoride simultaneously with some hydroxyapatite or calcium products, fluoride will create some kind of coating on the top of enamel. And this layer will not let the molecule of calcium to go through and go to the core of this white spot lesion. So during your remineralization stage, you use just products with hydroxyapatite or calcium or maybe ACCP, the tooth mousse product, for example. And then you go on and you add some fluoride products later. Okay, so Instead of using hydroxyapatites, you can also use the GC2 Smooth, which also has a lot of publications on its efficiency. And this is actually one of the most studied products for remineralizing teeth. So you can use this one as well. Okay, so another question is about the glass fiber tubes. So I honestly had several questions about this technique. So I combined all of them into this slide, and I will give one answer. So first, what is the suitable size of fiberglass tape using for reinforcement cases, as there are small, medium, and large? And the doctor asks that she wanted to know if we can use impregnated glass fiber tape. And also I showed you one brand which I'm using in my practice. So maybe it's not available in every country. So some dentists ask me which are some other options of glass fiber tape which you can use. So first, what I would like to answer is about the size, about the width of the tape. And usually those tapes are provided in several widths. It's 2, 3, and 4 millimeters. So I prefer to use either 3 or 4 millimeters. 4 millimeters, it's better for central incisors, and 3 millimeters can be used, for example, for laterals. About the impregnation part, I prefer to use a non-impregnated one because it's much easier to work with it, because as you remember, we need to fold it with the tweezers and using a plugger. So if it will be impregnated, usually there is a lot of resin inside the tape, and it sticks to your gloves, it sticks to your instruments. So for me, I tried it once, and for me it was not handy. So that's why I suggest you, if you would like to try this technique, to use a non-impregnated one and just use the adhesive system which you are using in your everyday practice, and put some adhesive, and you will not put as much, so it will be more handy to work with it. As to the products which can be available on the market, of course, I think it's better for you to ask the representatives of the materials in your country. But I can show you here some more examples which are actually available in Europe, for example. And as I told you before, I prefer to use this Polyglass, which is a Ukrainian brand. And it's really handy to use it, and it's honestly quite cheap. Okay, so it has a very reasonable price. But if it's not available in your country, and maybe now it's a bit difficult to order it, so you can try to use the fiber splint from Polydentia, which is the Italian brand, or you can try the Sanaden, which is also an Italian brand. And they are non-impregnated ones, so you use it in the same way like I use it with a Polyglass. Okay, but they maybe have some different different properties, like when you will try to fold it. But I tried to work with Sanaden, I tried to work with the Polydentia. I still like Polyglass the most, but it's also an alternative if you don't have something like this in your country. And there was also a question from another pediatric dentist from our course, and she said, she asked how long does it take for me to place this post system, and if I have ever tried just using the rebond fibers or some other fibers. I should say that there is a technique when you just take this glass fiber tape and you can just pack it inside the root canal, in this root canal orifice, and use it like a core, like a reinforcement system. But the point of using technique which I showed you is to have some macromechanical retention, because when you have this tube, you put it inside the root canal, and if you try to do it, I hope all of you have already tried it, maybe on some model or even in the patient's mouth. And when you try to put it inside the canal, you will feel that it's getting stuck in there. So this is the point, to get not just micro mechanical retention from adhesive system, but to get some macro retention. Because if we don't have this macro retention, there is actually no need at all to use any reinforcement system. Okay, so that's why I don't use any glass fiber tapes or posts which don't provide me any macro mechanical retention. And as to the speed of the treatment, I prepare all those tubes before the patient comes to my clinic. And for me, it doesn't take too much time. It's like 5 minutes to create this tube, because I know how to do it. My assistant knows how to do it. And we do it very fast. We create it fast. And I prepare them before the appointment, because I know that, for example, the patient will come and he has some completely destroyed anteriors. So I make those tubes, I put them in the alcohol just to remove some dust and some oil from the handpiece. And I store them afterwards in some box, so they are dry after it. And when the patient comes, you've seen the technique, you've seen the video, that it actually takes not a long time to put it inside the root canal orifice and create the core. And then you just put 2 more layers of composite and you're done. So I don't think it takes too much time, as long as you prepare this tube before the appointment. Okay, next question is like this. I'd like to ask, when you're radical and you're opting for extraction rather than putting a child in general anesthesia. For example, if a child has early childhood caries only on the upper front teeth from 5-3 to 6-3, do you put the child in general anesthesia, or are you trying to treat the child differently, or be more radical and in the worst scenario extraction? Well, honestly, if I can manage the behavior, I don't go for general anesthesia. But again, if I see that I can save the teeth, I will save them. So for me, it's not like, I will just go for extraction just to avoid general anesthesia, because it's easy. So I see the diagnosis, okay? So if it's just caries, why should I extract those teeth? We can first stabilize caries. For example, if we cannot go for GA for some reasons, or it's not reasonable to go for general anesthesia. So we can go just for arresting caries. This is first option. Second option is trying to adapt the child and go for restorative treatment. And we have different options. We have been speaking about it. We have composites, we have crowns. It can be some temporary glass ionomer filling. So this is also an option. Of course, if we are dealing with some complicated caries, let's say reversible or irreversible pulpitis, again, I understand that I need to perform some endodontic treatment first, and then I will restore those teeth. And after I make a plan in my head, I think how I will manage behavior in this child. And I've shown you that sometimes even in very small children, we go for conservative treatment without any general anesthesia, and it works quite well. So it depends on individual clinical case. And when do I go for extractions? I go for extractions in those cases when I see that the prognosis of my endodontic treatment will be very poor. Of course, if the child is very uncooperative and there is a risk of complications of some endo treatment, I will definitely go for extraction. If I'm working in general anesthesia, I'm more radical. So if I think there can be some complications, usually it's when we are treating some apical periodontitis, right? So if I was working in a regular chairside setting under local anesthesia, maybe I would give this tooth a chance to survive much more often than if I'm working in GA. But of course, the treatment choice will depend not only on my preferences, but it will depend also on the preferences of the parents, because we are working in a triangle. It's not just me and the patient, right? Pediatric dentistry, it's about the team, the triangle between the patient, the parents, and the dental team. So sometimes parents are insisting on saving a tooth which has a compromised prognosis. Of course, if I see that there is a risk for maybe development of the germ of the permanent tooth or a risk of generalized infection, I would insist on extraction. But if I see that we can try to save this tooth, and parents are willing to do that, and they sign the papers, because it's very important to actually sign the documents that they know about the complications and they are ready to take the risks together with us. So in such cases, sometimes I save those teeth which seemed to be hopeless. But mostly I go for such treatments if it's a local anesthesia treatment. Of course, in general anesthesias, we are more radical. I hope I answered this question for you. Okay, and this is another question of this doctor, and she asked that she is interested, what do I think about genetics and the risk of tooth decay, and why is the early childhood caries so extensive in some children and not in the others, and can genetics be involved in that process? Of course, it's a little bit different topic. I think it's a big topic. It's not about just restorations. It's about the etiology of caries lesions. But I would like to tell you that in my practice, I prefer to think about caries as a disease in the integrative way. So it's not for me just a lesion in the tooth, okay? I look at this disease in general, and we always try to examine a patient, make like a complete examination, not only in the oral cavity, but I also ask them to examine the gastrointestinal tract. I ask them to go to the otolaryngologist and see if they don't have any problems with the nasopharyngeal health. Why is it important? Because we understand that caries is a biofilm-mediated disease. And of course, we understand that in biofilm, there are different species of bacteria. And it's very important to have a balance between the bad guys and the good guys, right? But the bad guys do not reproduce just because of the sugar. For example, if the child is a mouth breather, the salivary function is not, saliva is not working as a protective factor so much, and the plaque gets more thick, it sticks to the teeth. So how can we work with the biofilm and how can we reduce the number of bad bacteria in such cases without working with the mouth breathing? It's not possible, right? So we have to work with the otolaryngologist together. Or, for example, if a patient has some gastrointestinal tract problems, let's say the bile flow is kind of slow, and if there is some problems with the bile flow, usually first the child will have some deficiencies of the fat-soluble vitamins like vitamin D, vitamin A, vitamin K, which are very important for tooth mineralization. So how can we work just on supplementing and correcting nutritional deficiencies, let's say supplementing with vitamin D, if the child and his gastrointestinal tract cannot digest the products which contain this vitamin, okay? So it's very important to look at the person in general and to work with caries in the integrative motion. And of course, we need to understand that this is a non-infectious disease. So it's not like the mother kisses the child and the child gets sick with caries. And if you are asking about the genetic component, yes, of course, teeth are the derivative of connective tissue. And sometimes there are some genetic problems with connective tissue, okay? Of course, this child who had some genetic problems, he will be more susceptible to caries. But we have to think about such a term as epigenetics. So in the means of caries and working with caries, we can influence genetics and modify the style of life, modify the diet, modify the overall health of the child. And by this means, the child will be healthy. But of course, if the child will eat a lot of sugars, the child will not have any healthy gastrointestinal tract, mouth breathing, and some more maybe health problems. Of course, this child will have caries, and the risk of caries will be much, much higher than in a healthy individual. Also, we need to consider that this disease is dynamic, and maybe today, when the child is healthy and the overall health is okay, there is a lower risk of caries, and tomorrow it can be a different situation. Okay, so as I said, there is an influence of genetic factor on caries, but it's not that caries is a genetic disease. There are a lot of factors which can influence this genetics, and we as doctors can identify those risks and help the child and the parents to have a healthy oral cavity. Okay, so now I would go to the chat, and if you have some more questions, let's discuss them. Okay. So I would like you to write down your questions in chat, and I will answer them. Yeah, so there is a doctor who is asking if you can write down the questions in chat. So yes, please write down all your questions, and we will discuss everything you're interested in on the topic of anterior restorations. So, does anybody have any questions? Maybe some of you have tried to make those tubes or make any homework that I gave you in our Instagram group. And if you had some difficulties while you were trying some techniques, you can ask me now, and I will try to explain better and maybe help you with the answers. Okay, so there is one question. Do you light cure after you impregnate the surface of the fiber before adding bulk fill? No, it's very important not to light cure it, because it will be hard, and then it will be not possible to fold it. So please go ahead and look and go through the video which is downloaded in your playlist again. Okay, so it's important to put some adhesive and then put some bulk fill. After that, your assistant helps you to fold this fiber with the tweezers, and only after that you hold the tweezers very tight, try to push it very hard to the plugger, okay? And the assistant helps you to cure. So it's very important to follow these steps. Okay. Okay, there are some more questions. You show stunning pictures of your work in the course. I have two questions. How do you keep mouth open under general anesthesia when rubber dam is in situ? How does the mouth wedge works with the clamps? Okay, so let me answer these first questions, and then I will go to the second one. So about how we keep the mouth open, I asked my anesthesiologist to make intubation through the nose, which really helps me a lot. But honestly, even when I had intubations through the mouth, I still used the same technique, which I will explain you now. So we put some Optragate isolation system. I showed it to you during the course as well. This is the Optragate from Ivoclar. And as soon as you put Optragate on, you don't remove it. And after that, you put Rubberdam on. And Optragate helps you to keep the mouth open. This is how you can isolate the whole jaw at one time. Because otherwise, if you don't put Optragate, you will have to put some bite block on one side, and you can work only on the quadrant or two quadrants at the same time. And it's not a good thing because you lose time like this. And if you isolate the whole jaw, of course, you will save some time, okay? So I suggest you to try to do it like this, without any bite blocks. Your excavations are absolutely clean. Do you work more with burr or more with a hand excavator? So usually I do like this. I remove enamel using burr, and when I get to the dentin, I use excavator, and the excavator should be sharp. This is very important. That's why I suggest you to buy some LM excavators, because in my opinion, they are the best, because they keep being sharp during a long time, even if they're not new. Because if the excavator is not sharp, you will not be able to clean dentin as you want it to be cleaned, okay? And with the burr, there is always more risk to penetrate the pulp chamber. So go on with the LM excavator, remove the dentin, the infected dentin. And then if you want to maybe correct some spots, you can use a burr in a very tiny and very slow motion. But on enamel, of course, we work with a burr. When there is a deep bite with a patient, in one case you said, I chose strip crown. Is it okay if we choose zirconia in deep bite cases? Yes, of course it's okay. The point was that I wanted to use a full coverage restoration in such cases, because if you just, I remember the case you were asking about, it was the third class cavity. So if you just go ahead and feel it like a third class cavity without any beveling, without going on the vestibular surface at least, you might have a failure in some time, because the occlusal load in such cases is much higher, and it's much more difficult to keep the restoration in place. And so in such cases, I either go for strip crown or maybe just full coverage restoration using a freehand modeling technique, or you can also go with the zirconia crown, of course. The only thing about the zirconia crowns that I would like to remind you is that they do not have any attrition of the material in the future. So we need to keep this in mind when we restore completely destroyed teeth. And we were speaking about this during the course. Okay, so next question. Hello, and thank you for the lovely course. Thank you very much. If the tube is too thick, do you cut from the tube or do you make an orifice bigger? You can actually combine both. You know, what I would suggest you to do is, I don't know which kind of glass fiber tape you will use. And for example, because I said before that maybe the one that I use will be not available in your country. So what I would suggest you to do is, you can just try to fold the tube, cure it, and then in the video I showed you that I put some more bulk fill composite around the fiber. If you go through the video again, you will understand what I'm speaking about. So if you are working in the central incisors where the root canals are wider, you can go ahead and put just a little thin coat of this bulk fill material around the glass fiber tape after you folded the tube. But if you're working in the lateral incisor, maybe it's enough just to leave the simple glass fiber tape. So you impregnate it, you put some bulk fill composite, you fold it with the tweezers, you light cure, and then you just cut this little tail, let's say, right? You cut this little piece of the tape, which is not needed, just to leave the tube. And I think that for lateral incisors, in some cases, it's enough just to have this amount of material, okay? Just a tape which is impregnated, basically. If you made this tube, but you see that it is too thick, you try to remove more material around the tube. Okay, also what is important is you need to use a thin plugger. The plugger should be like 1.5 millimeters in diameter. And if you, for example, use plugger, the condenser plugger from LM, they have two sides. One is a thicker side and another is a thinner side. So I would go with the thinner side. And it's better if the plugger is quite thin, because sometimes, you know, it's kind of divergating to the working surface. So then if you use a divergating one, you will have one side of the tube which is going to be thin and another one is going to be wider if the plugger is like a conic shape. But if it's straight, then you will have a nice tube. So this is another tip. And of course, you can, you know, extend a little bit the orifice as well, but make sure you don't leave very thin walls. So of course, it's better, always better to reduce some composite around the tube, or just skip the step of putting some bulk fill around the tube after you folded it. So you can maybe make several sizes, couple of tubes for centrals which have some composite around, and some tubes which don't have that composite, and then you will try them in the mouth and you will see which one fits better. And then after that, I think you will understand what is better for you for the future cases. Also, I don't remember if I explained this in the course, but I would like to repeat it. If sometimes you put the tube inside the orifice and it's not staying straight, okay, but you don't want to just extend the orifice more because you see that there are not too much tissues, but you feel that the tube is sticking inside, that you get this macromechanical retention, I would go and place it like this. But then when you cure it, you can take a burr, and if the tube is inclined a little bit to the vestibular side, you just remove a little bit of the material and it's okay. Don't worry, it's okay. Just what I do next, I remove the material, I leave it straight so that it will not be sticking out to the front too much, or to the palatal side, for example. And after that, I don't etch it. I just put a little bit more adhesive on the surface which was cut. Basically, it's the adhesive which was left on the micro brush after bonding. And I blow it with the air, I cure it, and that's it. And then I proceed with the modeling composite, with putting some more layers of composite. Okay, so I hope you've got the answer. In some cases, you said you choose mineralization method first. What do you use in this process? I think you probably joined the webinar a little bit later. So if you go, we will put some recording on the playlist, because I've been speaking about this topic at the beginning and I explained which mineralization protocol I use. So after we finish and we download this webinar, you can go ahead and watch the beginning and you will get the answer, okay? Okay, so next question is, hello, Dr. Peshko, your work is so inspiring. I thank you so much for such words. And can you tell me, please, what specific blood analysis would you advise when you see high caries risk? You know, there is no specific blood analysis, unfortunately. So what I actually do is I study nutritional medicine, and in nutritional medicine we have some questionnaires about the overall health of the patient. So I give them this questionnaire, and there are some questions like, for example, how the child sleeps, if he has good appetite, if he has cold or cold hands, if the child gets too tired during walk. So these kind of questions. It's not about the caries, right? It's about the overall health. And I know the symptoms of deficiencies which are which are specific for some mineral or vitamin deficiency. So when I read this questionnaire, I say, okay, for you, it's good to take this test. And for other person, it will be another test. But most of the time, I prefer to check the total blood serum test because in most of the early childhood caries risk patients, there is some iron deficiency, some vitamin D deficiency, some vitamin B12 deficiency, protein deficiency. So most of the time I check these parameters. And also if I see something else in the questionnaire, I go ahead and explore more. But basically, if I want to see if the child is deficient in iron, I take the total blood serum test, I take the ferritin test for sure. And then if I don't see what I want to see, if I need some more examinations, we can go ahead and examine more, like do some transferrin test, the iron in the serum and stuff like this. Next, we check the B9 and B12 vitamins. As I said, if the child is deficient, he would probably be in a risk group. Of course, we check the vitamin D. It's the 25-DOH vitamin. It's a serum test for vitamin D, and it's good when the the references are in the highest level. So basically this is it, but of course you can also go ahead and check more and more, like the gastrointestinal function, and for that you might need to cooperate with some doctors, some other specialties like a gastroenterologist, otolaryngologist, as I said before, maybe allergologist. So I think for you it's the best to have a team of specialists. Like in our clinic, for example, we have a pediatrician who is also a nutritional therapist. And if I have some problems with my diagnostics, I can also refer these patients to her. So this is how I work. So the conclusion is that unfortunately there is no analysis to indicate, just no single analysis or test to indicate the risk of caries. We need to ask the patient about different symptoms from the side of the gastrointestinal tract. We need to speak what the child eats, if the child has allergies, if the child has a mouth breathing or some other, maybe enlarged tonsils, or the child doesn't breathe because of the allergic reactions. And after that, you understand maybe what else you need to explore and examine, okay? So I hope I answered this question, because this topic is very wide, and I hope maybe one day we will make a course on it if you will be interested. Okay, so next question is, which zirconia brand do you prefer and which cement do you use for cementation? I should say that I started my career using NuSmile zirconia crowns, and I really like those crowns for back teeth. But for the front teeth, honestly, I think they need a lot of reduction, too much. So after that, I was searching for some other options, and I also tried the kids' e-crowns from some Indian brands. I also really like their back crowns, but not the front ones. Again, the reason is because we need too much reduction. So what I did now is I have a technician in our lab who makes my own crowns. And in Ukraine, it's not very expensive. So the price for one crown ranges like from something like 20 euros, from 20 to 30 euros. So for me, it's easier to make my own design. And this is what we did. And we produced some crowns for front teeth, which don't need so much hard tissue reduction. and I really like them. We modified some crowns from NewSmile and from Kids eCrowns, and we produced our own crowns for posterior teeth. So now I don't have any problem. I can order the crowns and tomorrow, because it's a milling process. I have the STL files, and I just ask the technician and he mills the crown for me, and it can be ready next day. So I don't use any crowns from the well-known brands now. But for me, it's better because, as I said, I created my own design first, and I really like it. And second is that I can also play with the colors and with the shades. Because for me, the zirconia crowns, which are provided by different manufacturers, for me, they look too opaque. And when I put just one crown in the mouth, you can always see that this is a crown. Even if you put 4 crowns, and then you look when the child is smiling, you can always say that this is a zirconia crown. And I really want it to be more aesthetic. So I can order a lot of shades and match it with the teeth which I'm working with. So this is how I work now. But I used to work with NewSmile for a couple of years, just with NewSmile, and I also used the Kids eCrowns. Okay, which cement do I prefer for cementation? I prefer to use resin modified, sorry, not resin modified glass ionomer, but double cured self-adhesive composite cement. And I will explain why. If you go to the literature, actually, they say that resin modified glass ionomer cement is the best for that purpose, but I tried it once, and the patient was sitting in the chair. I cured the cement, the resin modified glass ionomer cement. I cured everything according to the instruction. And then I was done. And I'm glad it was not a general anesthesia. It was a chairside case, because what happened, my patient went to pick the present after appointment. And while she was choosing the present, she just took the crown out of her mouth and showed me. So the cement was not cured fully. And what is the problem with the resin modified glass ionomer cements? With that, some of them, maybe it's those which I tried, but they cure for a longer period than this self-adhesive composite cement. So for me, it's easier and better to use the self-adhesive composite cement because it's easier to cure it. It cures very fast. And it's easy to clean the, like what I do is I put the crown, I cure it for like 1-2 seconds. I remove the remnants of the cement around the crown, and then I proceed with light curing, and I'm done. It never fails immediately. I mean, of course, it can fail in the future, and especially if the core is made of some artificial material, because usually the cements are made to be, kind of stuck to the enamel surface or dentin surface, like right to the natural tissues. And I think you also noticed that crowns which are put on the natural tissues stay in the mouth much better and much longer than those which were cemented on the artificial core. So sometimes after several years, I had some debondings, but it can happen to everyone, and it can happen also to the resin modified glass ionomer cement. Okay, and if you want to know the brand name, I can type it here now for you. So it's the one from 3M. It's let me check. 3M U200, Reliax U200. U200, the one that I showed you, which I use for cementation of the core of the totally destroyed, remember when we were reconstructing the totally destroyed incisor, and I told you that if there will be some debonding in the future, you have this restoration with a small tube, so you can cement it with this cement. So in those cases, I use the same cement. It's 3M Reliax U200, or you can also use the one from Panavia. I also use it and I have quite good results with it, long-term results. And I'm using the Breeze. Breeze, I think it's from the Genpentron brand, okay? But most of the time I use the one from 3M. Okay, so let me go back to see the answer, to see the questions. I was very surprised with the age of patients under general anesthesia. How long are the cases when all 4 anteriors are affected? Okay, according to the FDA recommendations, we shouldn't extend the working time more than 3 hours when we work with such little patients. But of course, if we restore just 4 anteriors, it's not 3 hours, it's not more than 1 hour together with all the work which is done by the anesthesiologic team, because you know, if you work in GA, that it takes around 15 minutes at least to get started. So if we are doing, for example, 4 pulpotomies and 4 restorations, it's not more than an hour together with the all the work which is done with the anesthesiologic team. And there are studies which prove if you are using sevoflurane for such anesthesias in children under 1.5 to 2 years old, and you work under 2 hours, it's completely safe. Also, of course, there should be all the measures for safety taken, so it should be an experienced team, it should be done with the intubation, and not just anesthesiologist who comes and sits close to the patient. So this is how it goes. Of course, if it's a full mouth rehabilitation, it can take more time, but again, we try to not extend 3 hours limit, and we do it, we actually plan the treatment in such a way so that we can manage it in 3 hours. But in Ukraine, parents really don't want to extract. They try to save teeth as much as possible. And, you know, a lot of parents also want to have teeth restored. So, for example, if we take into consideration silver diamine fluoride, it's not accepted by most of the patients who come to my practice. And sometimes it's very difficult to arrest caries without restorative part, okay? Because the child feels pain, it's not possible to brush those teeth, and if the child is not brushing well, how can we stabilize caries? Even if we modify the diet, even if we can correct all the nutritional deficiencies, if there will be a lot of plaque on the tooth, it's not possible to arrest caries. So in those cases, we just have to go for restorative work. And in my practice, I know that glass ionomer cement fails in anterior segment, and I don't know if it will stay there for 1 month or 3 months or 6 months. And you know, we always discuss this with patients when they come for consultation, and I give them different options. If I see that this caries needs restoration, I say that we can use glass ionomer cement because it's easier, for example, than just do restoration. Or we try to go for restoration, and you've seen that I showed you also cases done under local anesthesia, and those children were like under 2, right? So it's not that we always go for GA. So we also discuss this option, but we need to understand that at some point, at some stage, the child can refuse from this treatment and will cry, and we don't want to put the child under toxic stress. And if you speak about glass ionomer cement, I tell the parents the truth, that this cement will fail, and this is a temporary solution. So if they want to have a temporary solution, we can go for it, but it's very important that they know it from the beginning, and if it fails, they come and they pay for your work again, because I work in private practice. I believe all of you do the same, and you know, I have a lot of patients, and I don't want to work for free. Let's be honest, nobody wants to work for free. So as soon as the patient agrees with a temporary solution, and you know that it will fail, and you will replace it again and again, and you do want to do it like this, it's an option. If the parents do not want to pay every 3 months for a new filling, we go for general anesthesia. We try to stay with a time limit, which is recommended by different organizations and by the literature. And we try to do our best to make it as fast as possible. And as I said, for incisors with colpotomy, it's not more than an hour. Okay, so do you prefer heavy or medium rubber dam sheet? I never work with medium because I think it doesn't provide a good isolation. I usually have some leakage with medium, so I either use a heavy sheet, but dark blue from Sanctuary for the chairside settings, and I use the silk blue one. It's a light blue one, which is also heavy, but it's more stiff. If you try it and you hold it in your hands, you will see the difference between them. So that silk blue one from Sanctuary Dam is the one that I usually use for general anesthesia cases, because it provides even better isolation and you don't have any leakage. But it's more difficult to put it on because of its stiffness. Okay, so that's why I don't use it for chairside settings. Do you ever raise the bite of the child with crowns in deep bite cases to relieve the anteriors? You know that if you put the zirconia crown in the front region, you will change the bite a little bit anyways, because it's a prefabricated crown, it's not the individual one. But I do not use them for orthodontic purposes, let's say, because usually we do not correct any orthodontic problems in such ages. Only if there are some shifts, the functional shifts, then we can do it. But for example, with a deep bite, if the patient has a genetic deep bite and the skull is growing in that direction, it's much better to work on this during the teenage stage, because then the growth will be completing, and you will have a chance to control it during this growth span. It's my opinion. For example, if you have some crossbite on one tooth, you can put a crown in the way to correct this crossbite in order to prevent the functional shifts of the jaw. Or you can make some occlusal composite, you can put some composite on occlusal surfaces and modify the bite to correct these shifts. But I usually don't use crowns for that. I use composite mostly. As far as I understand, because composite shed over time, you mostly prefer composite restorations when the patient is young. Can we say if the patient is under 3 years, mostly composite is preferred? In some cases, you said because the caries risk is high, although the patient is small, you prefer zirconia. In such situations, do you say to the parents, maybe we can lose them in 2 years' time? How you discuss the material choice between composite and zirconia crowns before the general anesthesia with parents? Yes, I tell the parents all the risks. I want to be honest with them. And if I have completely destroyed incisors, I tell them that if we extract these teeth, we will not have any risks. But do you want to extract? I would not go for extraction if I know that I can save this tooth, if I at least have a chance. If it was my child, I would go for restoration. Okay, so if I see that the risk of endodontic treatment failure is not high, then I try to go for restoration. If the parents agree, of course. If they don't agree, we can extract those teeth and make a Gropper appliance. Then there is a choice between zirconia and composite. And I tell to the parents that, okay, with zirconia, what is a good thing? For me, for example, the time of restoration is the same for zirconia and for composite. So for me, it doesn't really matter which type of restoration I choose in the matter of speed. Okay, because this is an important factor if we work with kids. How fast can we do it? Second, the oral hygiene level. If we put, I tell to the parents that if I put zirconia crowns, for you as a parent, it will be much easier to brush the child's teeth in this region especially, because zirconia crowns don't accumulate plaque too much. and after the tooth will be erupting, and maybe we will have some enamel. If you use, for example, composite restorations, you might have a problem in this area if we go for composites, and you will probably not have a problem with the secondary caries if we go for crowns. So if I see that the parents are quite compliant, and I see that they will follow all the recommendations, they will really try their best on oral hygiene, and they will modify the diet, and they will work on the overall health of the child, I can tell them that you can choose both zirconia crowns or composites. In the way of discussing the oral hygiene issue. And as to the failure rate and the debonding, honestly, I think the risks are the same. But what I noticed in my practice, that over the time, this is why I actually told you this during the course, that over the time, I think that crowns fail more if we restored completely destroyed incisors in small patients. They just debond together with the core. And it doesn't happen with the composites. So this is why I made the conclusion that in the means of stability, long-term stability of the restoration, composite might be better in small children with completely destroyed incisors, because all my patients who have this kind of restorations with reinforcement, they have these restorations until exfoliation. And with zirconia crowns, I have some failures, unfortunately. After 2 or 3 years of having zirconia crowns in the mouth, sometimes I have debonding, not just of the crown, but of the whole core. And I can explain this only because the occlusion is changing, the tooth is erupting, and the crown doesn't have any attrition. So sometimes the occlusal load is too much, and it doesn't, it can just stay there. So I tell to the parents that we have risks in any case, because this is a completely destroyed tooth. And as I said, if we go for extractions, there are no risks. If we go for restorations, either zirconia or composite, there is a risk of failure. And if there will be failure, we will go on and we will fix it. How? We have to discuss it at the beginning. Okay, so if the child will be too small, so most of the time, if I have this core and they bring me the crown, I will just put it back. I will use the self-adhesive composite cement, and I will fix this crown back. If, for example, they come to the clinic and they don't bring me the restoration back, and the child is still too small and not cooperative, maybe I would consider just to close this root for a while. And I, of course, will not go for general anesthesia again. And I will close this root for a while, and I will wait until the child will get some more cooperativeness. So we discuss all these issues at the consultation. But most of the time, the crowns and the restorations stay at least for 2-3 years. And then the child is much older and more cooperative, right? So let's summarize. For me, if I see that the oral hygiene is very bad, if the patients are not compliant, and I see that they will not follow my recommendations, so they will just treat those teeth and they will go on with the same diet, with the same oral hygiene habits, then it's better to put crowns. But of course, you tell them that there are risks of failure in the future. And they have to sign the papers that they know about it. And if I know the patients are very compliant and they will follow all my recommendations according to the oral hygiene and diet and everything else, then I would go for composites if the child is very small and has totally destroyed incisors. If there is some structure left, some natural tooth structure left, it doesn't really matter if you use the crowns or composite restorations. The crowns will be fixed quite well on those teeth. This is just my observations. In order to avoid pulp exposure for indirect pulp treatment in anteriors, would you leave affected dentin, and what liner would you use? First, I would like to say that I do not use any liners because adhesive is actually a liner by itself. And there are studies about the indirect pulp treatment where authors say that you can use, of course, glass ionomer cement, you can use the calcium silicate cements like MTA or Biodentin or bioceramics. You can also use zinc oxide eugenol like IRM. You can use calcium hydroxide, but this is not the best option because it shrinks a lot. And then you get some micro leakage. And you can also use adhesive for that purposes. So I think that why should we build a sandwich and make our work more difficult? Because those teeth, the anterior teeth, are very tiny, they're very small. So when we put a liner and then a restoration, it's a two-step. We spend time first, and second, we don't have too much space for sometimes we don't have too much space for restorative material after a liner. So I just go on and I put adhesive and that's it. And it's not dangerous for the pulp, if you mean this, okay, by asking about the liners. And if I do avoid how do I avoid the pulp exposure if I leave some affected dentin? So I explained this also in the lectures that there are different clinical situations. And for example, if we are working with a completely destroyed tooth or severely destroyed tooth, I would go for complete excavation because I want to have healthy tissues for adhesion. If I don't have too much surface of tissues left, and I want to provide a good surface for adhesive dentistry, for adhesive restoration, I would like to have a clean working field without any affected carious dentin. So I would go and excavate all the dentin, which is excavated by excavator. I would not use a burr, but I would use excavator until I get to those dry dentin flakes, okay? But not soft flakes, but dry flakes. But if, for example, I was working in a first-class cavity where I could clean the walls and provide the good sealing restoration by just adhering my material to the walls of the cavity, in those cases, you can use some affected dentin in the bottom and it will work much better than in, for example, anterior restorations. Because in first-class cavities, we have a lot of space and a lot of surface for a good adhesion of our future restoration. And when we clean the walls, we can provide this good sealing restoration. Okay, so because this is very important, the good sealing ability of the restoration is very important for the future success of your indirect pulp treatment. So it depends on the case, if I remove all the dentin or not. Did you ever use reinforcement under zirconia crowns? If the patient is very young and uncooperative, you said you mostly go for strip crowns to be fast. It doesn't work for me. How can you prepare from all the surfaces before putting the strip crowns when the patient is uncooperative? Okay, it depends about the uncooperative patient. It depends on the case. And sometimes I go for the direct modeling. Sometimes I can go for zirconia crowns. So I think if you work with the uncooperative patients without any sedation, you choose the technique which you are the best in. Okay, so all of those techniques work. Strip crowns work, modified strip crowns work good. For me, direct modeling works very well. For somebody else, zirconia crown is faster. So you choose the technique you are the best in and your manual skills are the best in and the fastest technique for you, okay? So if you're speaking about the reinforcement under zirconia crowns, yes, I use the same system and I use this tube. If I see that the core is destroyed, the crown is completely destroyed, I use the tube and I build the core with a bulk fill composite just immediately. Okay, so as you remember, we cement this tube using bulk fill composite And if you go for composite restoration, I don't put too much of the bulk fill, but if I proceed with zirconia crown, I would just put a lot of bulk fill and cure it together with the tube. And this is like the first step, then you prepare it and then you put the crown. This is how I do it. You can also try to use glass ionomer cement. And I know that some authors have publications about this technique. Like, for example, Professor Osam El-Shahaba from Egypt, he has a publication about, I think I mentioned this publication in the course, that they restore the cores of completely destroyed incisors with glass ionomer cement, and then they put the zirconia crowns. But if you go to that publication, you will see that success rate of those restorations is also like 75–80% after a couple of years. So we will still have a lot of failures. We will have debonding of the core together with the crown, unfortunately. Okay, but you can use the reinforcement system that I showed you. If we choose zirconia crowns with 2-year-old patients, we will still be a failure in 2–3 years' time if we place it under the occlusal plane or if we use reinforcement. Honestly, if the bite changes and you have the occlusal overload, this reinforcement system will not help you with the zirconia crowns, because I had debondings of crowns which were reinforced using this technique which I showed you. But all of these debondings, they happened after, as I said, a couple of years. That's why I think the reason is that the crown is erupting, and it is erupting. If you compare, for example, if you make some photos of your zirconia crowns which were placed in the mouth, immediately post-op, then after 1 year, after 2 years, after 3 years, you will see that the clinical crowns are becoming longer. Okay, and if you follow up the composite restorations, you can also see that there is a small gap. There is some space between the margin of the restoration and the cervical margin of the tooth in a couple of years. So it means that the teeth are exfoliating a little bit, and the bite will be changing. And in some cases, the reinforcement, unfortunately, will not help. I'm not saying about 100% of cases, but for me, for example, even 30–25% of failures, it's not good. Okay, it's not good, because patients come to you and I want, they pay money, and I want to be sure that my work will stay until the end, until the eruption of the permanent tooth. So I cannot predict if the crown will not debond in such completely destroyed cases. I mean, zirconia crown. Thanks for answering all my questions, and I really admire your work. Thank you very much. And another question of mine is, in some cases you used space maintainers for anterior like Gropper appliance. Do you place them under sedation when the child is so young? Do you change it as the child gets older? Okay, so for Gropper appliances, it's better not to place them when the child is under 3. So if we have to extract some anteriors, I tell to the parents that we will have to place the space maintainer when the child gets older. So the child will have to be without teeth for some time, unfortunately. Why? It's because of the growing patterns. It's better to go when the child is older than 3. And also the child gets a little bit more cooperative, so it's easier to take an impression. But if, for example, you extracted the teeth when the child is already 3 or 3.5, and then you want to make the space maintainer, of course, I will look how cooperative the child is, and if I can place this appliance. I will not go for general anesthesia just to place the appliance. It's not, the emergency, it's not the necessity. So I will wait until the child will let me do it. Or even if a child cries a little bit, maybe, the child is playing with the tray, the impression tray, and I put it in the mouth, and the child gets a little bit scared, but it takes like 15 seconds to take the impression with alginate. So I take it very fast, and also we don't put a lot of alginate material in the tray, because we don't need to make the impression of the whole palate. Actually, we just need the teeth, so it's easier for a child to tolerate it. And then when we put the appliance, I also use glass ionomer cements, which are more tolerant for moisture environment in the mouth. And I just use those glass ionomer cements for cementation. And they should be double cured so that you can cure it very fast. I asked my assistant, and we have 2 curing lamps. At the same time, we cure the appliance from both sides, and it takes like 10-20 seconds. So even if the child is not very happy with that, we can fix it very fast, and it's not a toxic stress for him. So of course I will not go for sedation. So you can choose, either you go for management like this, or you wait until the child will be fully cooperative and you place it later. Okay, depends on the case. When you use reinforcement with freehand technique, you place composite in one big piece. How about the composite shrinkage in this situation respectfully? I use glass ionomer cement when bonding zirconia because I mostly can't stop bleeding. How do you stop bleeding with adhesive cement? It's more sensitive to the blood. Okay, first question about the shrinkage. I understand that it can shrink, but I showed you the follow-up of my restorations, and you see that they stay for a long time. So I think we can close our eyes a little bit on this shrinkage. And after the child comes for checkups, if you see that you need a little bit more polishing in the area of the margin of the restoration, you can polish it a little bit so that the margin and adaptation will be much better. And in the means of chipping the material, if you mean this, the restoration will fail because of shrinking, no, it doesn't fail. It sticks there and it stays there for a long time. If, for example, you use a strip crown, let's say, it's even worse, right? Because the strip crown is stretching the material. And when I'm using the freehand technique, I'm packing it, so it's much, much better. And as to the glass ionomer cement and the bleeding control, I prefer to use the hydrogen peroxide to stop bleeding, and it helps a lot. It helps a lot. Okay, do you use caries markers when applying indirect pulp treatment? I'm mostly afraid to do indirect pulp treatment, but I am treating the child under general anesthesia because in terms of pain, I would have to treat again. How do you choose the case? I do not use caries markers because the dentin in these patients, in small patients, or let's say in primary teeth or in young permanent teeth, it's always hypomineralized. So we will always have this dye inside the dentin. And by this means you are more aggressive and you will definitely go until the pulp. And you will penetrate the pulp chamber. So I do not use the caries marker. And how do I understand that I need to stop? So I use the excavator and I excavate the dentin. When I have this oh my God, let's say dry flakes, okay, the dry flakes, when you get to the dry dentin flakes, you can stop. And when the flakes are wet, like cheese, when you excavate and you have this wet, cheesy flakes of dentin, it means that it's not the time to stop. So I go until the hard dentin, and even if it's pigmented, I can leave it there. So basically, it's the feeling of the excavator and of the touch. And of course, you have to think about the anamnesis, about the X-rays, about the symptoms, and endodontic anamnesis is an art, honestly. And yes, of course, we can treat the reversible pulpitis also by pulpotomy, either partial or full pulpotomy, but it doesn't mean that pulpotomy doesn't give you any complications. There is always a risk. Okay, so as I said, I use excavator and until I get to the dry dentin flakes. Which camera do you use for photo shoots? Can you advise a professional one for a starter? I honestly don't remember the model. Maybe I can look and I will write you in the Instagram, okay? In this Pedodontics Pro practice, I will be at my clinic and I will take a picture, but I use Canon and also we have a Nikon. So you can just buy a professional one. And if you want a specific characteristics, specific model, I can send you these photos, okay, to the group. What system of local anesthesia do you use? I mean, you do use STA or similar systems. I use the let me type it here. I'll use the DentaPen system. It's the one from a Swiss brand. It's a Swiss brand, but now Septodont bought this device also, and they are also selling it. It's also a digital anesthesia device, so I prefer to use it in my practice. Okay, do you observe crown discoloration with a white MTA's pulpotomy agent in front teeth on follow-ups? Well, white MTA, I don't really use it. I use different materials. But there are some publications which say that white MTA can also stain a little bit. So it depends on how thick is the composite material which is covering this MTA, if you can kind of mask it or not. Okay. Just a second. Let me go back. Which MTA brand do you use and do you apply? So, okay, I would advise you to go for our Easy Endo course, because these are questions, all the questions about MTA and the protocol for pulpotomy are honestly from, they are really good discussed in that course. And I think for you to just understand it better, you know, because if I start explaining it now, it will be just some steps and some words. So I think for you, it's a very good thing if you would like to learn more about the indirect pulp treatment and how do we manage those cases and also the pulpotomy. I would just suggest you to go ahead and take our Easy Endo course because I see that all these questions about the treatment of reversible pulpitis are from one and the same person. So I'm sorry, but I'm sorry, I will not answer this question because it's a long lecture, okay? So pulpotomies and all this is about the other course. So if you have any more questions about the direct composite restorations of the anterior teeth, you can type them down. And I will wait for a couple of more minutes. Okay. When treating the patient under local anesthesia, you mostly wait 1-3 months before proceeding the treatment after temporary feeling. Is it because you want to see the results of the endodontic treatment? No, it's because I would like to, well, I showed you some cases when we waited from 1 to 3 months because those children were very small. These were cases of children under 2 years old. So for them, if I was treating them without any sedation, first, the treatment was very difficult. So I wanted them to have some break. Second, I couldn't use rubber dam because of their age. And usually if we have some completely destroyed teeth or severely destroyed teeth with early childhood caries, we have some gingival inflammation. And if I don't use rubber dam, I want the gingival tissues to heal before I go for composite restoration, because for me, it will be much easier and faster to restore the tooth when the gingiva is healthy. I would not use any hemostatic solutions. It will be fast and predictable. So that's why I put in those cases a temporary glass ionomer filling. I let the patient go, and this patient actually gets the healing of gingival tissues. And after 1 month, they can come again. And if I see that the patient can tolerate the treatment and we can proceed with restorative part, we go on and go with the restorative part. But if I see that the patient is not very cooperative, at least I relieve the pain. I did pulpotomies. I did some temporary solution. I did the temporary fillings with glass ionomer cement. And if I see that the glass ionomer cement looks okay, there is not too much shrinkage, I let the patient go for several more months, and then they come for checkup again and again until I can restore those teeth. So this is not because I want to see the result of my endo treatment, it's because I want to get some better conditions for restorative work if I'm not working in general anesthesia. Okay, thank you for your time and a great course. Thank you so much for such words. I hope you enjoyed it. And also, which temporary glass ionomer brand you use in those cases. Honestly, it doesn't really matter which brand you choose. I prefer to work either with Ketak molar from 3M. I can type it down here. Or it's the Fuji 9 from GC 3M, Ketak molar. Or it's Fuji 9. You can also use like Equia or something else. But for me, for example, it's, as I said, a temporary solution. And as a temporary solution, it works quite well. Thank you so much for your time and all the answers. Thank you too. I hope the answers helped you to understand the topic better. It was a lovely discussion. Thank you. Maybe there will be peace in your land soon. I hope so. I hope so. What inspires you personally to grow? One quality of you that is responsible for your success. Well, you know, if I will not develop and grow, I will be bored. I'm such a person that I get bored easily if I'm not learning and bringing something new into my practice. And I think this is why I still am not burned out, because pediatric dentistry is a quite difficult job, let's be honest. It brings us a lot of positive emotions because kids are great, and you know, when they hug you or kiss you, when they see those teeth and they smile, it's always great to see those emotions, but they also are sometimes difficult, and we have to admit that. So for me, in order not to get burnt, it's very good to develop and learn. And I started with something simple. Then, you know, I learned how to make nice restorations, and it inspired me to have nice smiles, because I'm a visual person who likes aesthetics. Then I learned how to make crowns. After that, you know, I also went for some courses like hypnosis or something else to develop my skills in behavior management. Then I started to work in general anesthesia. Then I started to work with nitrous oxide. So it's always something new. And when you work with something new, it's always interesting. And this is why I actually went to this nutritional medicine direction, because it's very interesting for me now to observe this integrative part of the caries risk and incorporate those knowledge into treatment of my patients. So I think if you learn a lot, you will never get bored. Okay, so this is probably why I still am in this profession. And if you love what you do, and I really love what I do, I really love my job. And, you know, I spent 3 months because of the war in a different country, and now I'm back home. And the first thing I did actually, next day when I came, I went to my clinic because I love what I do. And I think if you love what you do, you will always be successful. So I wish you the same. Love what you do, try your best, grow, and don't be afraid of trying something new, because all of us have some failures at the beginning, right? But sometimes the difficult road leads us to some beautiful places and to great success. So I would like to thank all of you for participating in this course. As I said, I hope it will help you to bring something new and into your practice and make it easier and make it more predictable. And I will be glad to see you in our future events. So another doctor says, thank you for sharing your extensive valuable knowledge. I thank you so much as well. Those things that I promised to send you, I will send as the answer about the camera. I will send it in the group in Instagram, and this webinar was recorded actually, and it will be also downloaded onto the platform so that you can watch it again. So thank you very much, and see you soon in some social media. I wish you good luck. Bye bye.